Hello, I'm Dr. Tom Schuler, Chairman of the Medical and Scientific Board of the National Spine Health Foundation. We are here to provide you with knowledge and an education how to overcome your spinal problems. We provide unparalleled access to the world's best experts. Here at Spine Talks, we welcome you and want to help you live a better life. Welcome to the National Spine Health Foundation Symposium on Lumbar Disc Replacements. We're fortunate to have world-class experts here to share with you. That's what Spine Talks is about, providing you direct access to world-class experts to answer your questions about your spine health. Today, we're going to start with this wonderful discussion about what disc replacements are in the low back and how they can benefit your life if you need them. My name is Dr. Thomas Schuler. I'm a spinal surgeon at the Virginia Spine Institute, and I'm the chairman of the Medical and Scientific Board of the National Spine Health Foundation. I've been doing lumbar and cervical artificial discs for close to 20 years, and I'm excited about this technology and feel that it's a real game changer for our patients. Scott Blumenthal from Texas, can you give us your background?
My name is Scott Blumenthal. I'm a spine surgeon at the Texas Back Institute. And as you'll hear from my partners as well, we're very passionate about both cervical and lumbar disc replacements. Of the two lumbar discs in the US, I was fortunate enough to do the first Charité, which is not on the market anymore. You hear from Jack Zigler that he started the Pro Disc study. We're very, very passionate about it. Tonight, you're gonna hear stuff that you just can't get anywhere else about disc replacement. So we're really excited to talk to you.
Matthew Gornet from St. Louis.
I'm Matt. I've been doing disc replacement since 2003. We participated in several FDA clinical trials, as well as my colleagues who are also my friends. And together, I think we've put together and authored numerous publications that have really pushed the science forward. I continue to do a lot of cervical disc replacements and a lot of lumbar disc replacements. And I think it's ideal, quite honestly, for the younger patients who have failed conservative measures. We see it often in people who are injured, workers' compensation, but also regular patients who had no injuries. And so, again, I think it is an improved technology, and we've been doing it for quite some time. And for our patients, it's really just an overnight stay.
Jack Zigler.
Yeah, I'm Jack Zigler. I'm one of the orthopedic spine surgeons at Texas Back. And like Scott, we were fortunate to be the right people in the right place at the right time, just when that technology came into the United States, and we participated very early on in the FDA trials. And as Matt Gornet mentioned, we were lucky enough to be able to follow our patients and to publish some of the really pivotal scientific information on following these patients. And we've been doing this now since 2000 and 2001 at Texas Back. So we've got some patients with literally 20-year follow-up who come in with their family members or for other issues. And it was kind of a hope and a prayer when we started it 20 years ago, but we now have generated good scientific evidence that shows that for the right condition in the right person, disc replacement both in the neck and in the lower back is a better phenomenon than a fusion is. And we'll talk a little bit more about that during the course of this discussion.
So I'm going to go back to Jack. You just introduced yourself, but you get to take the leadoff question. And can you describe for the public what a normal disc is? We're talking about disc replacements, but what is a normal disc and what does it do?
In the lower back, as in the neck, the discs are kind of cushions or shock absorbers in between the building blocks of the spine, which are the vertebrae or the individual bodies. So the discs are both protective, but they also allow motion. They allow us to compress and rebound if we jump off a curb onto a street. They allow us to twist and turn and bend and be flexible. But at the same time, they are helping to protect the nerves and the nerve tunnels behind it. And they can give us trouble in a couple of ways. The disc can break and a piece of it push on a nerve, and people get sciatica and sometimes need to have a piece of that disc removed so that the nerve doesn't have pressure. But the disc can also break internally, so it's a bad shock absorber. And when that happens, it can be very painful. Some people can live with it or get by with it, often helped with medicines or with therapy. But some people just never get over it, and it just cuts into your lifestyle. And there are a small percent of people who just need to have something done because otherwise their life's not worth living anymore. And that's when surgeons can offer them some opportunities for getting better with the right operation.
We talk about a lumbar disc herniation and maybe we need to remove it. And I think for the public, there's words out there such as a laminectomy, a fusion, a disc replacement. Can you just briefly summarize what the difference is in those?
I think to give the public a little bit better understanding, what you have to think about your spine, just like Jack said, is a structure, and that structure can feel and sense pain. If I twist your thumb backwards, it hurts, not because I'm pinching a nerve, but I've injured the structure. And most of orthopedic care that's musculoskeletal is really designed to fix structural problems, a problem in your shoulder, a problem in your knee. And in this situation, the spine is unique because nerves run through it. And so as the structure fails, it can irritate a nerve. And if it does so, and you only have nerve irritation and really not a lot of structural back pain, we can make a small incision on your back and do that very efficiently, outpatient. And we remove a small piece of bone, and that's called a laminotomy. Most of the people we treat for disc replacement, though, have a structural problem. They may also have leg pain, but their predominant problem is a structural problem with their discs. Their joints are okay, but their disc is bad. And that is the most common reason for people to visit the doctor other than the common cold is structural back pain. Usually it goes away, as Jack said, but in this situation, oftentimes it doesn't. And if that structural problem is still present, still persistent, that's when we get into structural solutions. One option that's been long tested is a fusion, but we're talking about new technologies today, which have shown to be superior to the older technologies, and that is disc replacement. So you can think about, I can fix the structure and stop motion, which is a fusion, or I can fix the structure and preserve motion. That's a disc replacement.
So when we talk about the anatomy of each level, I always look at each section, each mobile section as a 3-joint complex. You got a disc in the front and 2 little joints in the back called facet joints. And so it's these 3 joints that we're dependent on for motion at each level. In the disc replacements, we need healthy facet joints in the back to rely on to be able to replace that disc. Scott, can you tell the public what an artificial disc is, what we're actually doing?
Probably all of us started in practice and artificial disc wasn't around. We would do fusions for intractable back pain from disc degeneration. And I don't know how many patients that we all came across that said, well, how come you just can't replace the disc? And our orthopedic colleagues have been doing hip and knee replacements for decades, way ahead of us. And the fact of the matter is the original disc replacements is what we're using now are the same materials that are used for hip and knee replacements, just applied to the spine. And it took, some research, or actually a lot of research, some bioengineering, some technical expertise to create these entities, these disc replacements that can allow us to remove a damaged disc. And instead of locking the spine up with a fusion, which causes some secondary issues, which we can talk about later, it actually preserves the motion. So the 2 key things is relieve pain, preserve motion. And that's what these disc replacements do with, well-proven orthopedic materials, but now applied to the spine with more than 20 years of solid research.
It's so exciting. We truly have incredible technology. And I always call this the miracle of modern spine healthcare. And it's a game changer because motion is great. And we finally have found a way to treat the pain, the source of the pain, and preserve motion, which I think we'll all agree is the desired treatment. In fact, as 4 arthroplasty surgeons, I think that we all strongly believe in preserving motion whenever possible. How many levels of disc replacement have you done in the low back? And you can also comment on the neck while you're at it.
The original FDA trial for ProDisc was a single level study, but 4 months later, a 2-level study started, and it is now FDA approved for both 1 and 2 levels because those patients have been followed. The ActiveL study started a few years later, and it is FDA approved for single level. So those are what are called on-label applications, meaning that those were the parameters of a study that was done. There is off-label use that's permitted, meaning doctors are able legally and with the FDA's approval to use an implant, whatever it is, whether it's a plate or a screw or an artificial disc, outside of those label limits called off-label use, if it is in the patient's best interest to do it. So personally, I've done several patients with 3-level lumbar disc replacements and up to 4 levels in the cervical spine. Not often. I mean, in fact, it's pretty rare, but most of us have clinical experience that expands the labeling. And you know, we've got outcomes on those patients, but they are not the same scientific study group that the original FDA studies were.
I do a lot of disc replacements. I would say we've done hundreds of patients with 3 and 4 level, and we recently published a large article regarding that. It's interesting, the 3 and 4 level cervical disc replacements, the ones in the neck, do essentially just as well as the 2 level ones. And so there isn't an increase in complications or other problems. The patient outcomes are still good. In the lumbar spine, the most I've done on an individual patient was 3 levels. And I think it's important to note that it isn't about how many levels that we do. We will all do what's appropriate. The most important thing is matching the patient's structural problem with the appropriate structural solution. So why would we do more than 1 level, even though that was on the FDA clinical trials? Because if you have a 2-level problem, if there's 2 structural discs that are involved, treating 1 disc because that's on label will lead to a poor result. And if you want to know why oftentimes spine surgery is listed as not doing so well, it's because all the pathology has not been treated. So the surgeons on this panel, I'm quite confident, will treat the appropriate structural problem. In some patients, it's 2 levels, some patients it's 3. Usually, obviously, the majority of patients have a single level problem. So going to an appropriate surgeon, having them work you up so they feel confident that they will obtain a good result and treat all the structural problems, and that will then necessitate how many disc replacements you need or you're a candidate for.
And I'm going to kind of pile on to what both Jack and Matt said. And, you know, again, not frequently, but 3 levels lumbar, 4 levels cervical. And the really interesting thing is, and I think they both alluded to it, is not how much you technically can do, is what you should do. And every patient's different. And to try to match the right operation for the patient, because just because you have 4 bad discs doesn't mean you need to replace all 4 of them. And it's not always easy to figure out, but rather than just treating the MRI scan or the X-ray, is to really tailor it to the patients, which, you know, occasionally requires a bunch of visits and a bunch of tests. I think, you know, you'll end up getting a better result, and you'll be happier rather than blanketing and just say, oh, I'm just going to fix all 4, whether they need it or not.
Point of the question was just to show that in America, routinely, multi-level disc replacements are being done. 3 levels is not uncommon in the low back. 4 levels is not rare in the neck. The majority of cases are much less, but it's important to understand, and it comes down to this concept of the FDA. To get a device approved, you have to get FDA clearance, and that clearance is very specific parameters done in a study. And so when we get done, we have approval for a 1 or 2 level, depending on what the study was done. Nobody has done an FDA study on 3 and 4 levels. And the reason is it takes a lot of money and time to do it. And once you have a 1 and 2 level approval, physicians are not governed by the FDA as to what they do. Companies are governed as to how they can market a product, but physicians are not governed on how they can use that product. They can use it how they best determine for the benefit of the patient. The problem comes down is the insurance companies hide behind the concept that if it wasn't FDA approved, it's experimental. And I think from what we've heard from these 3 experts is that it's not experimental. It is a standard of care in select cases. And so it's important for the public to understand that just because an insurance company calls it experimental, it's not experimental. Does anybody have any additional comment on that?
The FDA has actually gone on record to say they do not go between the doctor and patient relationship. And so they do not have any problems whatsoever with off-label usage as long as your doctor has discussed it. Second is, and so to be very clear, this has even been brought up all the way through the court system, and the court system has uniformly in almost every state and federal has supported off-label usage between a doctor and a patient. And so this is not something that is experimental. It is already discussed by the FDA, and it's already been adjudicated. So I think your comments, Tom, were very important, because I think it does educate the public that this is not something that just a few rogue doctors are doing. This is permitted, and it's also permitted in all kinds of pharmaceuticals. If you go to the emergency room and have chest pain and take an aspirin, that is considered off-label usage for aspirin, yet we do it as a standard of care because we believe it provides benefit.
In Europe, they market to patients to say, oh, you can't get multi-level surgeries done in the US because the FDA won't allow it. And that's just not true. And it's kind of, to use a cliche, fake news, but it's one of the ways that the Europeans market. The problem is, and I think Matt alluded to it, or Tom, is that the insurance companies hide behind it. And what they tell us, and so as patients, you need to hear this, the insurance companies are saying, oh, we're not telling you not to do what's right for your patient. We're just telling you what we're going to pay for. And in most cases, the cost is prohibitive. So essentially, the insurance companies are rationing and denying appropriate care when all the other regulatory agencies say that appropriate, judicious, off-label use of a drug or device is okay.
One of our frustrations, and I'm sure a lot of the people listening will understand that, is that even if we are proposing an on-label use, that an insurance company can say, our medical policy considers this experimental. And that's just an internal business decision that they've made. And it flies in the face of 15 years of published data at a very high level of examination and evaluation. There's no device, no implant that we put in the body that has had the same level of scrutiny as lumbar artificial discs and cervical artificial discs. And yet they don't meet that same resistance. And it's very frustrating for our patients. It's very frustrating for us as well, because we have confidence that this is the right option for many patients.
People say they have to go to Europe to get their disc replacement or their multi-level disc replacement.
This goes back 20 some years. And obviously they've been doing it in Europe because of their regulatory systems different than ours. We had to get FDA approval for the 1 and 2 levels, as Jack alluded to earlier. And then once, we had FDA approval for a disc or two, then appropriate, judicious, off-label use was appropriate, was okay. But the Europeans had basically a decade head start on us. And at this point, the four of us on this particular seminar have had a lot of experience. And, back then, 20 years ago, had I done, or none of us have done 3-level disc replacement? No, because we just got the 1 and 2 levels, basically the 1 level approved. So at this point, that type of marketing is truly just fake news, to be honest.
All right, Matthew. So if lumbar artificial discs are so great, why would you even consider doing a fusion?
The way I look at it is this: the goal of a lumbar disc is provide stability and provide motion and relieve pain. But as you pointed out, because the spine has more than one structure that may hurt, if your joints in your back are arthritic, then if you preserve motion in the disc, then every time you move, you may move an arthritic joint that's painful. So generally, patients who have arthritic joints, we tend to favor doing a fusion on out of concern that motion preservation may lead to further pain. I think that we're starting to potentially rethink that a little bit, where people with maybe some moderate arthritis that before we would exclude may be considered candidates now, and the more data we get. But right now, that has been the tried and true method. If you have bad arthritis in your spine or even moderate, we tend to favor a fusion. So that's, at least in my practice, how I've done it. But I'm starting to rethink that based on some additional information we've had.
Those joints that Dr. Gornet's talking about are those little facet joints in the back of the spine. Again, that 3-joint complex, disc in the front, 2 little facet joints in the back. And when those facet joints are arthritic, that's the arthritis he was talking about. Would you ever combine an artificial disc and a fusion in an operation? And can you explain that?
That's something that was kind of born out of insurance necessity, occasionally out of patient's anatomy and pathology, but it's called a hybrid, where someone may have 2-level disc disease, for example, as Matthew mentioned before, where the L5S1 may be very collapsed, L4-5 may just have a damaged or broken disc, but still have motion. And in that case, we'll often do a fusion at the lower level, usually just from the front of the spine, the same as the approach we're taking for the artificial disc, and then an artificial disc above that. And that can also come in multiple level flavors, in addition to just 2-level flavors. And we've done enough of those now that we've been able to go back and look at our patient numbers. And we see that the outcomes for patients who have a hybrid, meaning a fusion as part of their construct along with artificial discs, do just about as well as patients who have multiple level artificial discs, and a lot better than patients who have multiple level fusions. So it just gives us more and more confidence that there is a value to motion, even if you can preserve it at only some of the levels. But a hybrid construct is very commonly done in the United States at this point.
Just to clarify for the public, we're talking about a disc replacement at one level of the spine and an artificial disc at another level. So these are at different levels, not at the same level.
A disc replacement at one level and a fusion at the other level.
Right. Scott, what's your thoughts on hybrids? How do you decide whether or not to do that?
The whole hybrid thing is just fascinating because, as we talked about earlier, when we first got FDA approval for the artificial disc, they'd only pay for one level. And so if they had a 2-level problem, we'd say, okay, let's do a fusion at one level, artificial disc at the other, so that the patients could get coverage. We looked at the data and they actually did really well. Then we talked to one of our colleagues in Australia who's done 500 or 600 of these hybrids, again, because of insurance. In Australia, they'll only pay for one lumbar disc. Excellent results. And then went back to Europe, and some of our colleagues in Europe that had no constraints because insurance said, well, sometimes particularly the lowest disc, L5S1, is pretty collapsed and it doesn't move much anyway. So we just fuse that and do the artificial disc above. And so through 3 separate venues, Europe, Australia, and US, and because of 3 separate reasons, we all kind of came to the same conclusion, which Jack just said earlier, is that in the right patient, the operation works as well, if not better, than multi-artificial disc, and certainly better than multi-level fusions. So that's kind of the history.
Matt, I know I've had conversations with you about disc replacements and determining hybrids versus multi-level and the age of the patient. Do you want to comment on that at all?
For my patient population, the younger groups who have more taller discs, I think, do better with motion preservation. But as Scott just mentioned, if your disc is very worn out, very collapsed, almost bone touching bone, you'll see that on the x-rays when you talk to your doctor. Those discs tend to be harder to mobilize, to get motion back in them, because the body has sort of auto-stabilized them over a period of years. That may be a candidate that is better served with a fusion. And so that's how we tend to look at it, at least in our practice. But the younger the patients, generally, disc replacement in my hands seems to be a better option. Remember, in the FDA clinical trials, the average age was 40 years old. So we're doing patients in their 30s all the time, and even younger. The youngest patient I've ever done was 18 years old. So disc replacement is a younger person's treatment. But what's interesting is, as we all age and we're healthier as we age, that has expanded way into the middle ages, as long as your bone quality is good. Anyone want to talk about
any experience converting a fusion to an artificial disc in the low back? I know it happens in the neck, but in the low back, does anybody have any experience with that? Or vice versa, taking an artificial disc and converting it to a fusion?
Well, Tom, the problem in the lumbar spine that's not as big an issue in the cervical is the dangers of a revision approach, a second approach, particularly at the levels where the great vessels, the aorta and the vena cava and the iliac veins can become scarred down to the front of the spine. So none of us is cavalier about making a second approach. So I think taking down a solid fusion would not be something I would ever recommend because of the risk of a secondary approach. Sometimes it has to be done the other way. If an artificial disc has a problem, if it slips or if the bone fractures around it, then we sometimes have to take that out, and in general, we'll do a fusion at that level. But it's the approach that's the risky part, and that's why we rely on very well-trained vascular surgeons to do the approaches for us and participate in the surgery.
Yeah, I think it's important for the public to understand there's very different anatomy in the neck and the low back. In the neck, there's no major vessels in the front of the spine. So to go back in is not a life-threatening operation, whereas in the low back, major vessels run down the front of the spine. And once they've been operated on, they get scarred down and they're harder to mobilize. And so that creates a much greater risk with redoing any surgery from the front in the low back. And again, these artificial discs are put in from the front in both the neck and the low back. And so that approach is very critical based on the anatomy. Matt, do you want to comment on what you would do with somebody who had a failed artificial disc if you had to stabilize it? How would you approach that?
The failures that we've seen really, quite honestly, are failures in bony anatomy. And so as we creep, and I would do this, patients who want motion preservation, and we push that into people who are in their 60s and beyond. I think that obviously we all know we get osteoporotic or osteoporosis or weakening of our bones as we age. And so my failures have come from that. We're getting better at that. And so when we've had to go back in, that is the circumstances where we're going back in, but we're going back in with a failure of the bone and the bone anatomy. In that situation, almost always you have to convert to a fusion and provide stability. Fortunately, that's very rare. Our revision rates on disc replacements are probably 1 to 2% tops, and usually early on, versus a chance of a failed fusion in the spine is much, much higher, and a revision rate for a spinal fusion is much, much higher. So I think if you consider all implants have potential issues or problems, lumbar disc replacement is just so superior in appropriately selected patients compared to fusion, especially looking at reoperations and revisions.
As Matt said, the comparison to fusion is without question in favor of disc replacement. And we had a very similar experience. We looked at our first 1,700 disc replacements, and currently we're over 3,000 at this point, and our revision rate was 1%. And I don't think there's been 17 in the next 1,700, so it's less than 1%. Now, do patients get problems at other levels? Sure, we're all getting older and our spines, you can have a problem at another level, but most of those can be handled, with standard surgery from the back. So you don't have to do, as Tom alluded to, that more life-threatening surgery of revision from the front. So our experience is similar to Matt's.
Question commonly asked by patients is, how do I find a surgeon that does artificial discs, and do all spine surgeons do them? And so I'd like everybody to comment on that.
Patients these days are so sophisticated, because I ask every patient I see, how'd you get to us? And invariably it was some really high level internet search, or a patient that's been to us, and the same names keep popping up. I mean, Dr. Gornet, Dr. Schuler, Dr. Zigler. I mean, the patients are getting very sophisticated, and they're not willing to settle for the occasional doer. There are centers and sites around the US that are doing this more frequently. And, and frankly, it's not just in spine. If someone needs, an advanced heart procedure, they're going to look where, which heart center does the most of their particular type of heart surgery. So, I think mostly now it's internet or word of mouth from previous patients.
For the most part, patients hear about it because they want something different. Everybody's had a friend who had a fusion that didn't do well. And it doesn't mean that fusions don't work. I don't want to imply that to the public, but we know that there are problems, and this is newer technology. It's better. And the illustration I would give my patients are, again, before we had knee replacement, we used to fuse the knee. Before we had hip replacement, we used to fuse the hips. We're not doing that anymore. And so this is a natural evolution, as I believe Scott talked about in materials. And I think that patients will come by word of mouth. And I think what Scott said is very important. If you're going to look up a doctor and potentially do that, it's very important to understand, do they do this routinely? How often? What problems have they had? How have they handled those problems? Those are all critical part of you as an educated public understanding how someone can treat you and what the benefits of those treatment are. And I think that's in everyday life.
All spine surgeons do fusions. We've all been trained very classically in that, no matter what generation we come from. But not all spine surgeons do artificial discs. Not all spine surgeons have chosen to get trained to do disc replacement. And many spine surgeons just choose not to do it as part of their practice. And I think one of the values of a forum like this is to educate patients that they need to ask the question. If a surgeon is telling them that they recommend a fusion over an artificial disc, they should say why and ask them to explain that, and then ask that surgeon, how many of these do you do? And you want to get that opinion from someone who can do both and do both well and is giving you their opinion based on experience, and not just because they only know how to do a fusion and choose not to do an artificial disc. So I think patients are more educated and sophisticated, but they also have to be able to talk to the doctor and ask that pointed question. Because, you know, we see patients for second opinions sometimes whose first opinion surgeon told them stuff that's not right. You know, they said these things are not proven, they fail, they don't work, and that's just not right. You know, there is, as I said, more evidence in support of lumbar disc replacements than there is of any plate and screw that we put in the body.
I think it's important to understand that artificial disc replacements in the neck or the low back are much more difficult to perform than a fusion. A fusion, well, none of this is easy. I would say that a fusion is a much simpler operation and doesn't require the precision that an artificial disc requires. Matthew, you want to comment on that?
Just think about a tire. If the tire is designed to move and it's a little out of line, it may still work, but it doesn't work as well. In this situation, the precision, I think you used that term, Tom, is very important. The precision of where it's placed, how it's placed, the height of it, the exact fit, whether it's going to put too much load on your bone and then put you at risk for other problems. All that is about precision. And having that experience and doing that is so critical. And I think what Jack just said, and I want to echo this, every single doctor on this panel tonight has done fusions and has participated in FDA clinical trials on fusions. But yet we're making these comments because we believe in this technology, and it is, I believe, so much better in appropriately selected patients. And so I think that's important for the public to understand that this is something we're passionate about, but we do both. As Jack pointed out, some doctors don't do disc replacements. We do both.
You can't be a one-trick pony. And the reality is that we look back at the patients that come see us for disc replacement, and 40% of them we disqualify for certain reasons, and we're not just going to do it just because the patient said. And the other thing, and Jack, please correct me if I'm wrong. I think it was Rolando Garcia has on his teaching slides, a good artificial disc surgery is better than a good fusion, but a bad artificial disc surgery is worse than a good or bad fusion. So that's something, and I think, that's what Matt said as well. You got to do it to the best of your ability every time.
Artificial discs work great when the right patient is selected and it's done by the right surgeon. Majority of surgeons do not do artificial discs. So it's important to understand that it's something that is an evolving technology. While it's not new to any of the people on this panel, it is a new technology for the vast majority of surgeons out there.
And Tom, I think it's a technology that should not be done by the occasional surgeon. It shouldn't be done by someone who just does this one or two a year. Just like I wouldn't do a large deformity surgery once or twice a year. I'd refer it to one of my colleagues who does it all the time, who understands the nuances and the techniques. I just have a strong feeling that if you want to get good outcomes, you have to go to someone who does a good number of patients on a regular basis.
There's been multiple generations of implants, and we've talked about some that are even off the market. And you gentlemen have all lived through this entire development of this technology. So I'd like to talk a little bit about the evolution of the implants and how critical is implant selection in the outcome, or is the surgeon's skill the most important with patient selection?
Patient selection is number one, and then the technical ability of the surgeon to do it is number 1A. I mean, that's kind of where it's at. The original disc in the US was the Charité disc, which is taken off the market, not really because it failed, but because it was not commercially successful. And we're seeing some of our 20-year follow-ups back with the original Charité disc that are doing magnificently. So, that's kind of where it's at. It's the right patient and the right surgeon, and it's something that the three of you guys have all alluded to, and I really couldn't agree with it more. There are subtle design differences between the two discs on the market now, which are the Pro Disc and the Active-L. But if it's the right patient and the right surgeon, the results are going to be pretty darn identical.
We're not using the same hips and knees that we used when they started back in the 70s and even 60s. And so it may surprise the public that the revision rate for a total hip replacement back when they first started was 50% at 5 years. Now it would be unusual you don't get a 15-year good outcome. So the materials have changed, what we understand has changed, how it fits in the spine has changed. The same sort of situation has evolved in disc replacement. The first discs, I think, were very good, but what we found was that sometimes the motion maybe was a little too much, and maybe it caused some early wear in the facet joints. Now, subsequent to that, though, the newer discs are what I call Generation 2, which is Active-L and Pro Disc, as Scott alluded to. Both of those work fairly equally well, and I think it has to do with the surgeon, their experience. And so I'm familiar with both. I've used both in level of hundreds on each, and I'm very happy with them. My predominant prosthesis I use now is Active-L because I like the slop in the system. The body tends to be able to accommodate to that. But other doctors who use Pro Disc, I would have no problem with that. I would say if you're getting good outcomes and positive outcomes, then that's the most important thing.
There have been other discs that have gone through the FDA process but have not passed it. They haven't gotten their certificate, and they've dropped out at various ways along the path, whether it's from materials or design. The two discs that are available now have kind of withstood the rigor of that FDA study, as well as lots of years of post-market use. In the cervical spine, as I'm sure has been covered in your other discussions, there are multiple discs that are available that are FDA approved with different designs and different materials. But in the lumbar spine, both discs have similar designs and exactly the same materials. And they are kind of like the original hip replacements. They are the workhorses. They will definitely be improved upon as time goes on. But so far, there is nothing in the pipeline that is looking better than these two discs.
And I'd like to actually pile on a little bit, and we've talked about it earlier, is some of the somewhat misleading marketing from Europe, because one of the things that they tell patients is that you can get discs in Europe you can't get in the US. But as Jack said, they haven't gone through the rigors of multi-year trials, and their proof is not as strong as what's available in the US.
We're talking about disc replacements, and I think people always look at a hip and a knee replacement and say, but okay, they last so long and then they fail. So what we should get as we get to the end of this, talk a little bit about what's down the road for a patient who gets a disc replacement. what's the chance of it failing? What's the knowledge of it failing? And then how would you salvage that?
Even with experience in Europe, where they've been doing artificial discs since the mid 80s with the original Charité, none have really been replaced for normal wear. And we know that the components that are tested for the FDA get the equivalent of 40 years of continuous grinding before there's material wear of the plastic component. And none of us puts that amount of 24/7 grinding on our discs. So although we don't know because we haven't been doing them for a lifetime, we are fairly confident telling patients that if properly implanted, these are probably lifetime implants. But having said that, if they fail, if the plastic component fails, they are made to settle and become stable. They can be stabilized with today's technology by fusing around it. But if they fail in 20 or 30 or 40 years, I'm very confident there'll be other technologies available that'll be safer for patients than revision operations from the front.
The failures that we see are really early on, and if you don't fail early on, I think you're going to do very well. Obviously, any patient can have a progression of their disease. No one expects to have a heart stent placed and never see the cardiologist again. And so I think from our standpoint, we follow our patients long term, but I'm not really worried about materials failure. I do exactly what Jack just said. I say these materials I think will last your lifetime. Other parts may fail, and we'll watch that and we'll follow you.
Totally agree with Matt. If there's a problem, it usually declares itself pretty darn early within the first 3 to 6 months. And the original studies on the part that can wear, which is the plastic, the polyethylene, in compared to hip replacements in the lumbar spine, it wears at 1/1000th of the rate that hips wear. So it's not likely that the plastic component's going to, melt away.
Yeah. I mean, while there's a large load on it, there's not the motion you get in a hip joint. And so we just don't see the forces. So I think like the real estate agents where it's location, 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 spine surgery, especially disc replacement surgery, it's patient selection, patient selection, patient selection. And that's really where the gift comes from the experienced surgeon is choosing the right individual to apply this technology to. Well, this has been a fascinating discussion, and I'm going to close with a request from our world-class panelists for one final word of advice to our patients about disc replacements or about spinal health in general.
If you've been told that you need a fusion, you owe it to yourself to look and discuss it with an expert to see if you're a candidate for a disc replacement. It's just, you owe it to yourself. The bar is raised, and like we said earlier, a good disc replacement beats a good fusion.
Patients that this technology is within reach financially and just from a medical standpoint. And if you go to appropriately selected surgeons, such as ones on this panel, they'll have programs that will allow to work with you so you can get what you need, and it'll be done in an expert fashion. And I think the most important thing is when it's done that way, you can look forward to getting your life back. And that's why we all are still doing what we're doing. It changes lives, and the positive part of that is still what brings all of us to the office every day.
Yeah, I'd say do your homework, do research, be prepared to challenge a surgeon who tells you you're not a candidate, and you may not be, but the surgeon ought to be able to justify that to your satisfaction. It's funny that Matt used those terms, because the most common comment that I get unsolicited from patients after disc replacements is, you gave me my life back, I should have done this sooner. And that just keeps coming back again and again and again. So there really is something good to this, and it does really change people's lives for the better.
That is fascinating. I like to say that a rolling stone gathers no moss, and motion is great, motion is healthy. So if you can preserve motion, preserve it. It's been an honor to chair this panel here today and have these experts share their knowledge with you. I hope that you've all gained knowledge, and I hope that this is giving you some hope for a better life. Thank you from Spine Talks.